to reduce the clutter on your table, you need a direction. So something like PrepLadder gives us that direction. You have some 40 hours or 50 hours of gynecology.
I have given all the content of pharmacology.
I've contributed the entire content for internal medicine.
I have created the content for PSM.
You can trust the questions and explanations to be genuine.
Detailed explanations will help you solve the different variations of the same question.
Textbook references will help you authenticate an answer.
I have created this content after close inspection of the previous year questions.
I have put in my 14 years of experience into creating these questions.
Includes the latest exam questions, questions on the recent updates, as well as image-based questions.
All questions are according to recent exam trends and difficulty level.
So the software would be exactly like the real exam.
All your queries come directly to me.
So if you have any kind of doubt, you can ask me directly.
I'll be solving all your microbiology related queries.
You can ask anything about the subject, doesn't have to be only about a question.
I'm always available for you whenever you need help.
You can have a counseling session with me.
So we've put in features to make sure you keep studying. The PrepLadder app will never let you fall behind.
Solving obs and gynae questions will be easy for you after this.
You would not have to worry about anatomy at all.
You will be able to solve most of the questions in PSM.
Most pathology questions in the exams are going to be derivatives or the repeats from these questions.
1 lakh competitors.
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 It's good to see that everyone in the team is giving their best.
This is the best team of faculties that could have been put together.
This is the biggest innovation in medical education.
We are obsessed with making sure that you get the best value out of every minute spent on the PrepLadder app.
Really happy to be a part of Team PrepLadder.
You know, if there was something like PrepLadder when I was preparing, I'm sure that I would have prepared much better because I would have known what to read.
Now we are going to discuss abdominal trauma. First, the one-liners which are frequently asked about abdominal trauma. So question: what is the most commonly injured organ in blunt trauma abdomen? Most commonly injured organ in blunt trauma abdomen is spleen, followed by liver. So that is spleen, followed by liver. After that, most commonly injured organ in penetrating trauma. In penetrating trauma, be careful, initially it was small intestine, but now it has been replaced by liver. According to ATLS 10th edition manual, it is liver, followed by stomach, followed by small intestine. So it's liver, followed by stomach, followed by small intestine. This is the latest change. You have to remember. Most commonly injured organ in penetrating trauma is liver, followed by stomach, followed by small intestine. After that, third question: most commonly injured organ in gunshot injury. In gunshot injury is small intestine. In gunshot injury is small intestine. After that, question is asked, what is the most commonly injured part of bowel in blunt trauma abdomen? Most commonly injured part of bowel in blunt trauma abdomen. That bowel should be mobile and fixed, and it is jejunum. So, most commonly injured bowel in blunt trauma abdomen, and that is jejunum. Question is asked, what is the most commonly injured structure in seat belt injury? So in seat belt injury, you must be knowing that most commonly injured structure is mesentery. So most commonly injured structure in seat belt injury, and that is mesentery. After that, question is asked, most common site of injury. Most common site of injury in deceleration. Most common site of injury in deceleration injury, and that is DJ, duodenojejunal junction, because that portion is fixed as well as mobile. The jejunum is mobile, duodenum is fixed, and that junction is fixed. That's why it's the most commonly injured site in deceleration injury. After that, 2-3 questions are asked regarding investigations in blunt trauma abdomen. Question: what is the first investigation done in patients of blunt trauma abdomen? Doesn't matter patient is stable or unstable. First investigation performed in blunt trauma abdomen is FAST, and the gold standard investigation performed in stable patients of blunt trauma abdomen is CET. First investigation done in blunt trauma abdomen patients is FAST, whereas gold standard investigation for stable patients of blunt trauma abdomen, and that is CET. That is CET. So these are the one-liner questions which are frequently asked about abdominal trauma. Before discussing blunt trauma and penetrating trauma, you should be knowing some basic concepts of trauma. First, we will discuss the investigations. First, we will discuss FAST and then DPL. It's very, very important. Nowadays, lots and lots of questions are being asked about FAST. So what is the full form of FAST? FAST is Focused Assessment with Sonography for Trauma. So FAST is Focused Assessment with sonography for trauma. So what is FAST? FAST is nothing. It's the emergency ultrasound which is done very fast. Emergency ultrasound which is done very fast. So question, within how much time you perform FAST? It's performed within 2 to 4 minutes. So it's emergency ultrasound. Performed very fast. Question was asked, how much time is required? It is performed within 2 to 4 minutes. This is a question. Performed within 2 to 4 minutes. So why we are going to perform fast? Because we want to assess the potential sites of thoraco abdominal injuries. Thoraco-abdominal injuries. So what we are going to assess in FAST? Usually we assess 4 P's in FAST. So what are those 4 P's which are assessed? The 4 P's assessed in FAST are pericardial sac, perihepatic region, perisplenic region, and pelvis. So we are going to assess 4 P's in the FAST, that is pericardial sac, perihepatic region, perisplenic region and pelvis. Now see how we are going to perform the FAST. So here you can see it's the sequential assessment of pericardial sac, perihepatic region, perisplenic region and pelvis. So what is that sequential assessment? Can you see this is 1, this is 2, this is 3 and this is 4. So we have to follow this proper sequence. So what are the traditional views in FAST? There are 4 traditional views in FAST. That is, first, you can see this one. This is the first one. This is subxiphoid. Be careful, this question was asked. Subxiphoid transverse view. And you know that this subxiphoid transverse view is used for pericardial sac. After that, you can see this second one. This second one is right upper quadrant longitudinal view. Right upper quadrant longitudinal view. And you know that this view is for perihepatic region. So this is for perihepatic region. Similarly, you can see this third one. This is left upper quadrant longitudinal view. Left upper quadrant longitudinal view, and this one is for perisplenic region. And you can see the fourth one. The fourth one is suprapubic. This is suprapubic. Be careful, longitudinal and transverse view. There is longitudinal and transverse view. Clear? This is for pelvis. This is for pelvis. So now you can see that there is sequential assessment of these 4 regions, 1, 2, 3 and 4. So how many views in FAST? There are total 4 views. Question is asked that what is E-FAST? E-FAST is also known as extended fast. It is also known as extended fast. In extended fast, there are 2 additional views. In extended fast, there are 2 additional views. And what are those 2 additional views? Right thoracic view and left thoracic view. So here you can see that this is right thoracic view and this is left thoracic view. So question is asked that how many views are there in E-FAST? Can you see? There are total 6 views. This is 5th one and this is 6th one. So these are the questions which are frequently asked about E-FAST. And in one exam, question was asked about E-FAST that what is the sign seen on E-FAST in patients of pneumothorax? So in patients of pneumothorax, there is barcode sign or stratosphere sign. So on E-fast, in patients of pneumothorax, there is barcode sign, that is also known as stratosphere sign. Barcode sign or stratosphere sign. So this is very important, and this was asked about E-fast in one exam. Now we are going to discuss DPL, diagnostic peritoneal lavage. But see, I already told you that FAST is the first investigation done in blunt trauma abdomen patients, and FAST actually replaced the DPL. So see the DPL. So DPL is diagnostic peritoneal lavage, and it is performed for the patients of blunt trauma abdomen. DPL, diagnostic peritoneal lavage. Just break the word and you will get the answer. What we are going to perform in DPL, can you see? We are going to perform peritoneal lavage. Why we are going to perform peritoneal lavage? To confirm some diagnosis. That's why it's diagnostic peritoneal lavage. It is performed for blunt trauma abdomen patients. Now see how we are going to perform. This is abdomen. This is umbilicus. Infraumbilical vertical incision is given. After that, we are supposed to insert one catheter, and that catheter is directed towards pelvis. After that, we are going to aspirate it. We are going to aspirate via catheter. After that, we are going to attach. After that, we are going to instill 1 liter of saline or ringer lactate into the peritoneal cavity. And then we re-aspirate that fluid for assessment. So see what we do in this case. In this case, first catheter is inserted. After infraumbilical incision, directed towards pelvis. Aspiration is done. After that, instill 1 liter of normal saline or ringer lactate for lavage, and re-aspiration is done. Re-aspiration of fluid is done, and this fluid is sent for examination. Now see how it's performed. So you can notice that in first case, what we are going to see, we are going to insert a DPL catheter, diagnostic peritoneal lavage catheter, and this catheter is directed towards the pelvis. It's directed towards the pelvis. After that, we are going to put 1 liter of saline or ringer lactate. So first we insert the catheter, we perform the aspiration. After aspiration, we have to instill 1 liter of saline. After that, can you see the same bag is reversed, and whatever the fluid is there, it is coming and collecting into this bag. And this fluid is sent for assessment, that whether there is presence of RBCs, WBCs, fecal matter, vegetable matter, and we are then going to find out whether DPL is positive or negative. So see in which cases we consider that DPL is positive. So DPL is considered positive if DPL is considered positive if more than 10 ml of frank blood is aspirated? More than 10 ml of frank blood is aspirated, or returned effluent contains returned effluent contains RBCs more than 1 lakh per mm cube, WBCs more than 500 per mm cube, presence of bile, bacteria, fecal matter, or vegetable matter. Fecal matter or vegetable matter. Or there is presence of what? Amylase. What should be the level? Level should be more than 175 international units per deciliter. So these are the situations in which we consider DPL as positive. Be careful in which situations fast or DPL is positive. It is positive only in two situations. What are those two situations? Either there is bleeding or there is perforation. Nothing else. So either there is bleeding or there is perforation. Then only fast or DPL is positive. So these are the two basic investigations. Now, whenever fast is positive, whenever fast is positive and the patient is stable, in that case we have sufficient amount of time to perform CCT to assess that what is the specific injury. Since CCT is the gold standard investigation for the diagnosis of stable patients of blunt trauma abdomen, after fast in stable patients, it has to be performed.